You also need to watch the PBS documentary, to which there is a link that you'll see in a minute, that looks at how other Western countries deliver health care to their populations. And what you're going to see is that it's not all, socialized medicine. There's lots of free market approaches that can be used to guarantee people access to health care. So that's what you're going to be watching in the films. And I suggest that you watch the films and then listen to the rest of the lecture. So the topic is American healthcare. So before Obamacare, you have the film Sicko, and then you have the film Sick Around the World. And I encourage you to watch those films now, if you haven't already done so, and then come back and pick up the lecture after you have watched the films. All right, now under Obamacare, we're going to be looking at a lot of information, data, and so forth about American healthcare under Obamacare. For now, I want to show you this. This will give you a sense of how much healthcare costs a typical family. So we're going to take a look here. And here's a typical family, right, with insurance provided by their employer. It's a family of 4 with an income of $150,000. You could take different income ranges, 50, 100, or 150, or average income. Let's take $100,000. Right? And you could take the health, let's say it's average health. So a family of 4 with $100,000 in income and employer coverage spends about $12,500 per year. That's out of pocket for health insurance, on their health, which is about, they say 13%. They're rounding it up. Obviously, easy math. It's 12.5% of their income. But if you look, there are state taxes. We pay a state income tax. A portion of that state income tax goes towards health care. So that's $1,250 for this family that earns $100,000. Health insurance premiums. Even though you get it from your employer, you still have a premium you have to pay. Part of it is paid by the employer, part of it is paid by the employee. So about $4,500. Federal taxes. As you can see here, federal taxes for health programs, income taxes for Medicare, marketplaces, Veterans Affairs, etc. FICA, Medicare Part A. All of that comes from your federal income taxes. And then there's your out-of-pocket costs. That's the co-pays, the deductibles, and other out-of-pocket costs that you pay for your health care. So it comes to over $1,000 a month, which is a big nut to have to meet month after month. That's the cost. So keep that in mind. And that is with health insurance. That's the cost on average. So you have this. You can look at this for different income levels, different levels of health, average, better, worse, and so forth. And you'll see it doesn't change all that much. But you have that. So you can take a look at that. And then there's after Obamacare. And I put a question mark. One thing we know is that Obamacare is not likely to remain in its current form after this year. There are going to be changes, and one of the changes that's being talked about is Medicare for all. So I want to take a look at this to give you just a very simple, very brief, very straightforward pros and cons of Medicare for all. It's a brief film.
the debates now heat up and play out in this political season, Medicare for All has actually many different meanings. Each of the candidates or proponents seems to have slightly different meaning. I think there is a core of an idea here. If I had to capture it, what all share in common, I guess, is first finding a way that everybody has health coverage, leaving no one out, and trying to simplify the world of coverage and payment so it's more consistent and maybe lower administrative costs. So some common channel of payment, bring it all together. The differences are how to achieve that, and so Medicare for All could literally mean taking Medicare, which is the coverage system we have for people over 65 in this country, and saying it now will cover everybody, and administered by a federal agency. We'd have to describe a new benefit package because Medicare doesn't cover obstetrics, so it doesn't have to. But so you have to come up with a different way to look at benefits. But it would be exactly what it sounds like. Medicare now is the insurance system for America, one pool. Medicare, Medicaid, commercial insurance is now one payment, one card. That's your American health insurance through Medicare. I think there are some common assumptions, misunderstandings about Medicare for All. The biggest one is a confusion between Medicare for All as a government administered payment system on the one hand, which it is, and a government takeover of delivery of care, like all the hospitals and doctors are now government employees, which it isn't. That's not what's being proposed. And I find lots of people get mixed up there. They say, no, we're only talking about the payment stream now. Simpler, more accountable, and public. Delivery system stays as you now know it. Another problem is the cost saving side, and this is confusing. So Medicare for All almost certainly would save money, a lot of money. We're spending $3 trillion on health care. I don't know the percent, but there's probably a double-digit percent decrease in that. That's a lot of money to become available. That money goes back to workers and to corporations that need to be competitive. It goes back to government so they can build houses and roads and schools. It goes back to other forms of economic investment in this country. That's true. But if you look at Medicare for All literally, you're taking private streams of payment from your employer, out of pocket from you, streams of payment that are costing you a lot, and you're unifying them in a government payment, which is, I guess, a tax. Call it a fee, call it a whatever, but it's a government fee. Now, in the rhetoric, the opponents point to say, "Oh, look at that! The government's expanding. You have this big tax bill now, and you're paying less than you would have otherwise, because that money is your money, whether it's coming from your employer or from out of pocket. It is your money. You're going to pay less of your money, but you're paying it to government, and that shift from private flows to public flows is very confusing to people, and it's a opportunity for a lot of demagoguery and misunderstanding. It's hard to sum up what the real pros and cons are, but I basically, the pros. A simplified system of payment, a government payment system, let's say through Medicare, has the advantage that it's simpler. So a lot of the administrative costs, which amount to 15% or more of the total bill, they'll go way down, because the Medicare system is a far more efficient administrative system. It just doesn't have all the paperwork and the coding and all that. It's simple. And it gets easier for doctors, easier for nurses, easier for hospitals, and easier for patients. So that's an advantage. Another is that if you literally could say Medicare for All, what happens now, you have a publicly accountable spokesperson for the interests of patients and families. The only job they have is to protect the beneficiaries. It's a public function, and there's no duty to stockholders or shareholders. There's no game going on here around profit. It's all about making sure people get the care they get. Another advantage is transparency. If you assume Medicare for All would be, as Medicare is, a public function, then under law, it has to report. It has to say what's going on, tell the prices. Think about your insurance company. Do you actually know the prices? Do you know what they're paying the doctor who just saw you, or how much they're actually paying the hospital for the MRI? You don't. You can't find out. Another advantage is we can have a public dialogue about where to put our funding. Your insurance company can decide right now that it just doesn't cover non-essential health benefits, and you have no recourse. Medicare is publicly accountable. You have to have that conversation in the open, and if someone raises a question, you darn well have to answer that question. And so you get a more transparent discussion of coverage. On the con side, we're talking basically about a larger role for government in purchasing. People that don't want big government get worried. They say, well, it's got to be a bureaucracy. And that's a management challenge. If we had Medicare for all, whoever wants to pursue that will have to think about how we're going to have a kind of management system that is really sensitive to localities, to states, to the public, instead of being a massive bureaucracy. Right now, the commercial insurer is kind of controlled by their stockholders or their boards of trustees and the economic interests. The Medicare for all, the new oversight is political. It has to be. It's government we're talking about. So you're going to have people change. People will lose their office and get elected. We deal with different presidents, different secretaries of Health and Human Services, different Congress people in oversight, and people do worry about that. And there's pushback on that account. Other people doubt that the savings will be as big as intended, because although we save a lot on administration, now you have lobbyists who can come in and argue for their new device or their pricing, and that will tend to drive prices back up a little bit. And so the argument that Medicare for all will save a lot of money is one that people have to struggle with that. Only if it's correctly set up and correctly managed would that be the case. If that is the case, there's a lot of money to save, though, and I think that's one of the advantages. I think people worry about control, because Medicare for all, if all the payment went through one channel, then you have a very powerful purchaser. Now, it's a purchaser on behalf of the public, publicly accountable, but it's a single purchaser. What does that mean? Is, well, the competitive market has gone away for provision. Medicare sets the prices. It decides what to pay for heart attacks. There's no competition on that. And frankly, the people that deliver care, the hospitals and the doctors, they're a little worried. They say, do you really want someone across the table from you who's such a powerful purchaser? The proponents say, yes, you do, because that purchaser's standing up for the interests of patients and trying to keep costs under control. The providers say, well, it's arbitrary. They'll take the money away that I need. So you're going to hear that debate.
Okay, so we're going to talk more about Medicare for all, and we're going to apply it to our current system and see what kinds of changes it would make. And we're going to do that. Well, and you can get more information. I'm sorry, you can get more information about Medicare for all at that site. That link at the bottom will give you more information about it if you're interested. All right, but we want to see how this might impact Americans, and we're going to do that by looking at American healthcare in sociological perspective. So, remember, you know what that means, I hope by now. How does the structure of the U.S. healthcare system impact general patterns of interaction in the United States? How does the macro structure, the institution, impact the way patterns of the way people think, act, and feel in regard to healthcare? That's American healthcare in sociological perspective. The one other point I want to make before we dive into this has to do with the concept of rationing. A lot of people who argue against Medicare for all or any kind of government involvement in the healthcare system is to say that government is going to then ration healthcare. And that's true. However, healthcare is currently rationed not by the government but by insurance companies and by the free market generally. Remember the economic concept that we talked about in the very beginning of the semester, scarcity. In economic terms, something is scarce if everyone cannot have as much of it as they would like. medical goods and services are certainly scarce. Everyone can't have as much of it as they would like. Therefore, the access to it has to be controlled. There has to be a way of determining who gets what. Do we want the free market to do that, or do we want more government involvement in making those kinds of decisions? The thesis of Sicko is pretty clear, that government should be more involved. So keep that in mind, that healthcare, like any other good and service, of course it's scarce, therefore it's rationed in some way or another. The question is not should it be rationed, the question is how will it be rationed, because it has to be, because it's scarce. All right, American healthcare and sociological perspective. So how does a private, for-profit healthcare system, which is what we have in the United States, impact health-related behavior in the United States? And we're going to look at it in 4 different sectors, I guess we'd say. Doctors and hospitals. In our system, they operate as businesses. And therefore, doctors and hospitals have the same concerns as any other business. They have to have enough revenue to cover their expenses. They have to hire and fire staff. They have to buy supplies, etc., etc. They operate as businesses. The hospitals and doctors that you saw in Britain, for example, they are not operating as businesses. They are owned and controlled and operated by the government. Doctors only focus on their patients' health care. They don't concern themselves with getting enough money to pay the electric bill, getting enough money to pay the nursing staff, etc., etc. So, but that's not our system. Our system is private. Doctors and hospitals are going to treat only those with the ability to pay, and that means you either have insurance or you have to be able to pay out of pocket. There aren't many people who can afford to pay all their medical bills out of pocket. If you call a doctor that you've never been to before to make an appointment, first question you'll be asked is who is your insurer? And if they accept that insurance, they'll accept you as a patient. If they don't accept that insurance, then they will not. Doctors in hospitals operate under a fee-for-service system. They see you, they provide you with medical services, they then bill your insurance company for those services, and the insurance companies will pay them a fee for each service that they provide. Fee for service. So it's not that the doctor gets paid a certain amount because you are his or her patient. The doctor gets paid based on the fee, based on the services that they provide, and they are reimbursed according to the fee schedule that is established by the insurance company. Insurers, therefore, determine what tests, procedures, therapies, surgeries, drugs, etc. are allowable. And as you saw in the film Sicko, they routinely deny claims. They routinely deny payment for a whole variety of procedures, therapies, surgeries, drugs, etc. If you have lived long enough, you will have gone through a situation in which your insurance company denied coverage for something that your doctor wanted you to have, whether it was a surgery, a therapy, or a prescription. I certainly have had a number of things that my doctors have recommended for me that my insurance company said they would not pay for. Here we see something that is kind of interesting development in terms of private doctor offices in the United States. This goes back to 2012, but this trend continues. Although the number of physicians in the United States is increasing, the percentage that remains solely in private practice is decreasing. So you could see 57%. There was 83,000 physicians in the United States in 2000. 57% of them were considered independent. The number of physicians has consistently increased, but the percent in private practice has been declining by about 2% a year. So what we're finding across the United States is that increasingly private doctor practices are being taken over by corporations. And it's happening for a number of reasons, but one of the reasons is in generations past, young doctors out of medical school, finish their internship, they're ready to start their own practice, would then either buy into an existing practice or they would purchase a practice from a doctor who was retiring. Now what we're finding is young doctors are not in a position to do that the way they had been in the past because of, you guessed it, their student debt. Doctors go to school for a long time. Medical school is very expensive. The typical medical school student is financing their education by taking out loans. They are beginning their professional career in lots of debt, which creates two problems for them. One, in terms of buying a practice. One, they don't really have money for a down payment. And two, because they are so stressed financially, banks are reluctant to give them loans, a business loan, to buy into a practice. So consequently, what young doctors do is they go to work for corporations. They get a steady paycheck, and they're able to repay their loans and so on and so forth. But keep in mind, this is a structural change in the delivery of health care in the United States. It's becoming more corporate than it has ever been before. And now doctors who are not independent are corporate employees. They are beholden to the corporation that has hired them. And that could very well have an impact on their medical opinions, their suggestions, and so forth, because they have to keep the corporate bottom line in mind. And that's a significant change that we've seen. In some areas of the country, it's a single corporation that owns the local hospital, owns the local pharmacy, owns the local doctors' practices, the general practitioners, as well as the specialists. And it's all connected to one corporation. And that's different than what we've seen in the past. So that's something that's happening, as far as a typical American is concerned, largely under the radar. Insurance companies. Insurance companies are motivated to deny claims. As I've mentioned, every time they pay a claim, they lose money. So of course, they don't want to pay claims. They want to deny them. They're going to refuse coverage in a private, for-profit healthcare system. They are going to refuse coverage to those who might require expensive or extensive care. People with pre-existing conditions and people who develop the need for very expensive or extensive care. Remember, the Affordable Care Act prohibits them from doing that, but what the Affordable Care Act has done is taken our private system and regulated it. That's an important thing to keep in mind. Remember the continuum that we did at the very beginning of the year when we talked about our economy, the continuum of market freedom. What the Affordable Care Act has done is reduce the freedom of insurance